Good evening, ladies and gentlemen, dear colleagues. It's my pleasure to welcome you on behalf of the European Society for Vascular Surgery and on behalf of our distinguished faculty to this fourth educational webinar called Improve Your Outcome in Revascularization, New Path and Antithrombotic Therapy. I'm very thankful to the ESVS and our sponsor, Bayer, that we are still able to continue with expert discussions and educational activities like these during these, as we have all admit, very special times. Please make use of the live chat box function, and you may ask your question anytime during the presentations. If you are using a PC, just on full screen, just use the escape button and then you'll see the live chat box and ask your questions. With no further ado, I would like now to hand over to Professor Henrik Sillesen from the University of Copenhagen, Denmark, who unfortunately is not able to join us here in the studio as initially planned. Hi, Henrik.
Hi, Rupert. Thank you very much, and also welcome to everybody participating from me in Copenhagen. Due to the COVID restrictions, we're not welcome anywhere, any of us probably. And if I would have had to go to Frankfurt, I would have first had to go there 2 weeks before in quarantine in a hotel probably. So I'm trying to do this from home, as the other panelists will also be from other locations. Let me upload my slides here and share with you. So I hope you see the slides now. And I will just give a short update on what have been put into the guidelines with this new path for antithrombotic therapy using the combination of low-dose rivaroxaban and aspirin. And these guidelines that I'm going to quote are all based on the data that came out with the COMPASS study and all the sub-analysis that we have seen. Nothing yet, to my knowledge, has been put into guidelines from the Voyager study. Let's begin with the European Society of Vascular Medicine. They have placed a so-called 2A recommendation for patients with PAD without a high risk of bleeding or any other contraindication. If you're unaware what a 2A means, it simply means that you should consider prescribing this medication to this patient if there is not a contraindication. So this is the second strongest recommendation that you can get using this classification system. And level of evidence B means there is one randomized controlled trial. And in this case, you can see this is just the COMPASS trial. If we look at the most recent guidelines joined by the European Society of Cardiology and the European Association for the Study of Diabetes, the EASD, they recommend that in patients with diabetes and chronic symptomatic lower extremity arterial disease, which is PAD, without a high bleeding risk, a combination of low-dose rivaroxaban 2.5 plus aspirin should be considered, again, similar to the Society of Vascular Medicine, a 2A recommended scientific level B. If we go to the most recent European Society of Cardiology guidelines for the management of chronic coronary syndromes, they also have a 2A recommendation for what they say, adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with high risk of ischemic events without high risk of bleeding. And high risk of ischemic events is noted at the bottom of what you see here. There's an asterisk. At least one of the following multi-vessel diffuse CAD plus diabetes or PAD or heart failure or reduced kidney function. So chronic CAD and PAD together elicits a 2A recommendation for this new path of antithrombotic therapy. And if we look into the most recent global vascular guidelines, and remember the global vascular guidelines were issued by the European Society, the ESVS, the American Society, the SVS, and the World Federation for Vascular Societies. They have these practice guidelines for chronic limb-threatening ischemia and stated that consider a low-dose aspirin and rivaroxaban 2.5 milligram twice per day to reduce adverse cardiovascular events and lower extremity events in patients with CLTI. The grading system here is a little bit different, but the reason why it is maybe stated as weak is that there were not that many patients with CLTI in the COMPASS trial, which this recommendation is based on. Nevertheless, it is put in there because it is considered to be an important point. And finally, in the newest guidelines from the ESVS, the guidelines for acute limb ischemia, the dual pathway inhibition is also mentioned to be considered in patients having had ALI, acute limb ischemia, realizing that this has not really been studied as a primary hypothesis. However, as stated in the last paragraph, a small subgroup of patients within the study, the COMPASS study, who had acute limb ischemia also had a marked reduction in amputation and mortality rate. Although the COMPASS trial was positive for patients with acute limb ischemia, this was not the primary endpoint. So having begun our webinar with this short summary of the current guidelines, let me introduce Professor Mark Nealer from the University of Colorado to present a patient that could come out of the COMPASS trial. Mark, please.
Thank you, Heinrich. I'm coming to you from Aurora, Colorado, and likewise, we're not allowed to travel anywhere because of the pandemic. So I'm sharing my screen. This is a patient that I think illustrates the COMPASS results. It's a 68-year-old male, former smoker, has hypertension, a history of coronary disease, had a coronary bypass graft 6 years ago, has claudication at 2 blocks, ankle brachial index is normal on the right and 0.75 on the left side. For medications, he takes aspirin, a atorvastatin, fairly high dose, and a angiotensin receptor blocker, losartan, for hypertension, as well as a beta blocker, atenolol. So if we look at the COMPASS paper that illustrated the peripheral arterial disease subgroup of that trial, shown here with Sonia Anand as the primary author, you can see that in their table, most of their patients were male, like this patient. This patient, former smoker, typical of about half of their patients. And importantly, the patient has claudication and symptomatic PAD, which represented 50% roughly of the peripheral arterial disease patients in that trial. His ABI is relatively representative of about 40% of the patients, and almost all were on a platelet agent. 8 out of 10 were on some sort of lipid-lowering agent, and another 70% or so were on an ARB, and 60% on a beta blocker. So he is a representative COMPASS patient with a number of criteria that were represented in the trial. And you can see the primary event of MI, stroke, or death was reduced significantly in the low-dose rivaroxaban and aspirin group on the green line here, with the separation that occurred quite early and continued throughout the trial that was almost 3 years. And then you also see an improvement, maybe that's as important or more important for the vascular surgery group, in limb events. The green line again, separation not quite as early, but happened over time. Significant reduction in acute limb ischemia, revascularizations, and major amputation. Now, one of the issues with the COMPASS trial is the number of patients with limb events, because this was a stable population. was relatively small. And then we have the follow-up Voyager trial where that's not the case, and will be discussed further in this webinar. So that sort of is an example patient, what can be expected in terms of benefit, both cardiovascular events and limb events, and sets the table for further cases and discussion. So I'll turn it over to Rupert, Professor Bowersox, to talk about the companion trial Voyager.
Yes, thank you very much, Mark. And I would like now to discuss with you the Voyager PAD trial. Here are my disclosures. I would like to start with reviewing the issue and the challenges that we have in patients undergoing acute revascularization, as opposed to the chronic patients that you, Mark, just mentioned. These are data from Connie Hess based on a large number of patients, almost 400,000. And what you can see is immediately after the intervention, there's an increase in the risk of major adverse limb events. There's a fourfold increase of acute limb ischemia. And you can also see that there is a continuous risk for those PAD patients suffering from major adverse cardiac events. And as we all know, of course, if a patient suffers from acute limb ischemia, this means hospitalization. It means also that 4% die immediately at presentation. We have an amputation rate of 20%. 1/3 of the patients need to stay on the ICU for a prolonged time. And of course, as you all know, 3/4 of those patients have to undergo major surgery. And the outcomes, really, the patient is hospitalized because of acute limb ischemia, is poor, and about 15% of the patients are disabled or dead. Now, what can we offer? What is the evidence that we have for antithrombotic treatment in those patients after revascularization? Unfortunately, we don't have a lot of evidence. We have two studies that I want to mention here. That's the CASPER study. That's a study looking at the comparison of dual antiplatelet treatment with aspirin and clopidogrel, comparing with aspirin alone in patients with vascular surgery. And the endpoint was graft occlusion, revascularization, major amputation, or death. And as you can see here, this was a negative trial. However, dual antiplatelet treatment led to an increase in major bleeding by a factor of 2.8. How about combining anticoagulation and platelet inhibition? That was studied in the Dutch BOA study in patients undergoing bypass surgery. And again, you can see that the addition of an oral anticoagulant did not provide any benefit with respect to graft occlusion, but again, with a combination of anticoagulation and platelet inhibition, this led to an increased risk of bleeding. Now, the combination of anticoagulation and platelet inhibition would make sense from a pathological point of view. And as we've just seen by the presentation of Professor Naylor, if you combine a very low dose of an anticoagulant, rivaroxaban 2.5 milligram BID with aspirin, and compare that with aspirin alone, you could see in the COMPASS study that this provided a great benefit to the PAD patients also and reduced male events. Now, COMPASS was on chronic patients with CAD or PAD. Voyager is a trial looking at symptomatic patients with PAD after recent revascularization within the first 10 days. You can see it was a large study, more than 6,500 patients were recruited and were either randomized to rivaroxaban plus aspirin or aspirin alone. And in addition, clopidogrel was allowed for up to 6 months. You can also see it was a large study and it was a long-term study. The mean treatment duration was about 30 months. And for us, I think it's important that this Voyager trial looked for the first time at a new outcome. It combined limb events, acute limb ischemia, major amputation of a vascular cause, myocardial infarction, ischemic stroke, or cardiovascular death. So limb events and major adverse cardiac events were combined as the efficacy endpoint, and you can see that the principal safety outcome was TIMI major bleeding. Patients were included with ischemic PAD, with symptomatic PAD, after successful lower extremity revascularization, and they were excluded if, for example, dual antiplatelet treatment was necessary for more than 6 months, or if the patient had a high risk of bleeding. These are the baseline characteristics in the Voyager trial. It's the typical population that we see with PAD. You see, again, more men than female, 26% female. You can see 40% had diabetes. Again, current smoking, more than 1/3 of the patients. And you can also see that about 1/5 of the patient had impaired renal function. Patients had to 1/3 a coronary artery disease, and patients received about 50% clopidogrel. High use of statin, actually, about 80%, and ACE inhibitors or ARB, so the baseline treatment was sufficient. You can see that about more than 1/3 of the patient had already prior revascularization. That even 6% had prior amputation, and the median ABI shows you that there is significant peripheral arterial disease. So median ABI was 0.56, and about 1/4 of the patient had critical limb ischemia. And that's very interesting, I think. About more than 1/3 of the patient underwent surgical revascularization. So we have more than 2,200 patients undergoing vascular surgery, and 2/3 of the patients received endovascular treatment. I mentioned that patients had to be enrolled within 10 days after the procedure. The median enrollment was after 5 days. And you can see here that 25% were enrolled before or day 2 after the revasc. Now, this is the primary efficacy results, and several points are important here to note. First of all, it's a positive study. It was significant reduction of the hazard ratio for suffering, one of those male and MACE endpoints. But I think it's also important to recognize there was a almost 20% event rate in those patients receiving only aspirin and clopidogrel in 50% of the patients. And that event rate was reduced from 19.9% to 17.3%. So that was an absolute risk reduction of 2.6, numbers needed to treat 39. Another thing is important, you can see that these curves really separate very early after the intervention or the surgery. So the effect of this low dose of rivaroxaban really became effective immediately. How about safety? What about the bleeding? The principal safety outcome was TIMI major bleeding, and you can see that numerically that was increased, hazard ratio 1.43, but that difference was not significant. If we look at the very severe bleeding, intracranial bleeding, fatal bleeding, or the sum of intracranial or fatal bleeding, you can see that there was no difference between rivaroxaban and placebo. If you look at further bleeding parameters like TIMI minor bleeding, again, there was a numerical increase, hazard ratio 1.5, that was not significant, or BARC3B bleeding, hazard ratio 1.29, not significant. Only if you look at the more sensitive bleeding parameter like ISTH major bleeding, hazard ratio 1.42, that was significantly different. This is the forest plot for the efficacy outcome in the different subgroups. And most importantly, there was no significant P of interaction, meaning that the results that we see overall with a hazard ratio of 0.85 is applicable to all subgroups. But I think it's also interesting to look at the qualifying procedure. If you look at the surgical subgroup, you can see that the hazard ratio was even lower. It was 0.79 for the surgical patients. And if you look at the forest plot for the, for the bleeding, let's go back. And this is shown here. This is the bleeding outcome. you can see that there was no difference with respect to the bleeding outcome in the surgical group, whether they received rivaroxaban or not. So overall, if you look at risk and benefit over time, you can see there was a slight increase of the bleeding risk in the beginning, but there was a continuous decrease of MACE, major adverse cardiac events, and limb events over the course of the study, and that continued throughout the study. So altogether, for every 10,000 patients treated, you prevent more than 180 events, and there were more than 29 principal safety outcomes with TIMI major bleeding during that time. So in summary, in symptomatic PAD patients after revascularization, 20% have an acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, or cardiovascular death at 3 years. In the Voyager study, rivaroxaban 2.5 milligram plus aspirin was associated with a 15% risk reduction of MACE in male, with no significant increase in TIMI major bleeding. Especially acute limb ischemia was reduced by 33% compared to the current standard of care, including clopidogrel. As I showed, the benefit was apparent very early and consistent over time. There was a consistent benefit across the major subgroups, and this treatment prevents 6 times more ischemic events relative to the bleedings that were associated. So the dual pathway inhibition treatment is now the only evidence-based antithrombotic treatment showing a significant benefit after peripheral revascularization in a large randomized controlled trial.
Thank you, Rupert. I think we should take the opportunity to maybe have some questions. I can see we got a couple coming in now. And first of all, I would like to just repeat your last sentence, this 6-to-1 ratio, because this is always the fear when we give extra antithrombotic therapy that we're going to cause damage. And these are patients that just underwent the operation. And still, we see this very nice ratio that we prevent 6 events for 1 bleeding caused. And we have this nice hazard ratio and very good outcomes. And I can see that one of the questions...
Henrik, just I want to comment on that, because there was, I didn't show the slide, but that's an important question that you address here. The number of take-back bleeds, so patients undergoing revasc and need to go back to the OR for bleeding, was extremely low. It was 0.8%, and it was 0.8% both in Riva and in the placebo group. So that number was very, very low, and exactly as you said, because that was something that, of course, everybody feared. And there is a question already, and I think that's very interesting, and that's saying the Voyager trial did not compare clopidogrel versus aspirin and rivaroxaban. Why? That's very important to make that clear. The comparison was rivaroxaban plus aspirin against aspirin alone, and clopidogrel was allowed. And it's very interesting to see that for the endovascular patients, a large proportion of the investigators and the doctors used clopidogrel, whereas for the surgical patients, the clopidogrel use was low. It was about 9% only. And we had to allow clopidogrel use according to local standards, and they are very variable. In different parts of the world, in different centers, the clopidogrel use was very different. So it's important to know there was no randomization for clopidogrel. And we will get some more data later on clopidogrel and how it performed here, but there's no comparison between rivaroxaban and clopidogrel. Unfortunately, we do not have any evidence by now for the use or the risk of clopidogrel after vascular surgery or after intervention.
We have another question. Maybe let me introduce Mark Needler again here. So this is actually outside the scope of peripheral arterial surgery, but it's very, very relevant, Mark. So we're being asked for AAA patients after surgery or EVAR. What treatment should they have?
Yeah, that's a very interesting question. I think if they have peripheral arterial disease, then some of the COMPASS data would be relevant. But for the Voyager data, the revascularization was limited to distal to the, external iliac artery distal to that. So, it's not really relevant for the AAA patients. But I think, that the COMPASS results also enrolled a large number of patients with coronary disease. So if the aneurysm patients have concomitant coronary disease, then I think those results are also relevant. Good question, though.
Yeah, it makes a lot of sense. And while you're there, this goes back to the Voyager trial, but I'm sure you can answer it also. For how long would you prescribe aspirin and rivaroxaban for high-risk patient post-revasc?
Well, interestingly, the separation happens almost immediately, and it carries out. So it continues to expand over the length of the trial. So I think our current strategy is probably, an indefinite treatment window presently, unless there's some sort of bleeding complication over time that might change the strategy. I think the other issue is, as we're going to talk about with the redo patients, we all know these patients end up getting multiple revascularizations over time. So even though they might end up transitioning initially from a Voyager patient to maybe over time a COMPASS patient, we all know that doesn't last. And then you end up getting another revascularization if they survive and are long-term players, in which case they sort of revert back to a Voyager patient.
Rupert, will you answer the next question and read it first?
Yeah, very good. It's a very good question because what about the last figure showed 15% reduction of MACE in male? Is it absolute risk reduction or relative risk reduction? And it's always important to look at both. It is a relative risk reduction of 15%, and I showed you also the absolute risk. And that's important to note. These patients have a very high absolute risk of almost 20%, and the absolute risk reduction is 2.6%. And so that translates into a number needed to treat of 39. So it's always good to look at, not only the relative risk, but also at the absolute risk. And unfortunately, these patients have a very high absolute risk.
Okay, well, maybe we should go on with some of the sub-study data from the Voyager trial, which we will enlighten with some more cases first. So Sebastian Debus, would you please proceed with your first case?
Yeah, thank you very much, Henrik, and all of you. Rupert actually gave a very nice transition to the clopidogrel group. And this is what I would like to point out now with presenting one fictive patient. These are my disclosures. And let us just go ahead with the short history of a 78-year-old male who was a retired carpenter. His history was a 4 weeks increasing difficulty to walk with right-sided calf pain after 10 meters eventually, and also with nocturnal pain in his right foot. He also had a cardiac history with a silent acute myocardial infarction around 10 years ago. He suffered from diabetes also since 10 years, and he was an ex-smoker with 80 pack years. His cholesterol level showed 55 milligrams per deciliter HDL-C and 100 milligrams per deciliter LDL-C. And here are his evaluations concerning blood pressure and ABIs. You see a typical ABI for a diabetic patient with sky-high levels in the anterior tibial artery and also the posterior tibial artery, exceeding an ABI of 1.3. On the affected side, no pulses were detectable. Let's go to the next slide. Here you see the initial angiography, which was also performed for therapy. You see this occlusion below the knee, very typical for a diabetic patient. And this is what was done. Next slide, please. Or no, here you see his cruropedal runoff with a patent posterior tibial artery and a peroneal artery also. Next slide. Then plain balloon angioplasty was performed first, which was then added with a plain balloon stent, as you can see here. And the distal runoff again showed a very nice result. Next slide, please. So the perfusion to his foot was restored, showing markedly increased ABI levels of 0.86. So a nice result, certainly, but now it is the question how to treat this patient post-intervention. And this patient would usually get aspirin plus clopidogrel, and due to his severe comorbidity with diabetes and silent myocardial infarction, coronary artery disease, we would place him on the Voyager regime. So it was interesting to see the subgroup analysis within the Voyager study, looking at the primary endpoint for those patients receiving clopidogrel, which were mainly the endo-treated group, against those patients without clopidogrel, meaning mainly patients which were surgically treated, but not only. And we need to be aware, if we look and interpret these results, that those were no randomized results, as Rupert already said earlier here. You see here in the clopidogrel group, with 3,300 patients included, an absolute risk reduction of 2.3%. Meaning a cumulative incidence decrease from 18.3 to 16.0% in patients receiving rivaroxaban plus aspirin plus clopidogrel. Compared to the opposite, without clopidogrel, here we have a quite similar absolute risk reduction, which is even a bit higher, of 2.8%. Next slide, please. And if we look to the secondary endpoints and compare the Riva group and the placebo group with and without clopidogrel, then we realize that not even one single subgroup here in terms of the secondary endpoints experiences a better result with clopidogrel compared without clopidogrel. Next slide, please. Hospitalization for coronary and peripheral events for a thrombotic nature is always very important to notice. And again, here we have to realize that there is no real difference between the clopidogrel group and the group without receiving clopidogrel. Although different absolute risk levels are here, this represents different treatment groups, of course, which are not directly comparable. However, risk reduction is even less in the clopidogrel group, with an absolute risk reduction of 2.6% compared to 4.2% without clopidogrel. Next slide, please. A very important point is safety, meaning bleeding rates with clopidogrel compared without clopidogrel. And what we can see here on the left side here, we have the group receiving clopidogrel, and here the group without receiving clopidogrel, and comparing bleeding rates. And we can see here that the clopidogrel data really show a marked increase of bleeding rates, both in placebo and in the rivaroxaban group compared to the group without clopidogrel, with a very relevant P interaction of 0.7. Next slide, please. If we look over the course of treatment with clopidogrel, when these bleeding exceeds happen, then we realize that these curves are accruing. However, already in the first 180 days, the large gap already happens. So we could conclude and interpret these curves as we say, if we think a patient needs clopidogrel, then we probably should give it as short as possible. Next slide, please. Can we go over to the next slide? Here we again see the benefit and the risk of rivaroxaban with and without clopidogrel. And we see here that the benefit for both groups with and without clopidogrel are slightly similar, with even a slightly higher benefit in the group without clopidogrel. The risk, however, is higher than in the group without clopidogrel. So we would conclude, next slide please, that the benefits for rivaroxaban are consistent regardless of background clopidogrel use or duration. The benefit of clopidogrel is uncertain, showing no separate benefit by itself. And finally, in patients receiving rivaroxaban 2.5 milligrams twice daily with aspirin, the addition of clopidogrel is associated with higher rates of bleeding, particularly with longer durations. So if we would come back to our patient now, and we think we should treat this patient with the Voyager policy, and we think we would need clopidogrel in addition, then I would think to leave this duration with clopidogrel as short as even possible, maybe 30 days. Thank you.
Thank you very much, Sebastian. That was very enlightening. And I think the take-home message is really what you say, that it appears to be within the first 6 months that the additional bleeding happens. So if we feel that clopidogrel is of any use, it should be within as short duration as possible. We have a question coming up, not really related to clopidogrel, but I think we should do it now anyway. And I'm going to ask this to Mark, because I believe that there were initially some American cost-effectiveness analysis done, or do I remember wrong? So we have a question. Are we likely to see a cost-effectiveness analysis?
Yes. Yes, I think that's part of the strategy moving forward with analyzing the Voyager results. That's something that is in the queue, but I don't believe, you can correct me if I'm wrong, Rupert, but I don't think that has yet to be put out in an abstract form. I think it's on the list, though.
Rupert is muted.
Oh, I'm muted. Okay, can you hear me now? Yeah, it's an important question, and we've noticed that the event rates are so high in those patients after the revascularization, and the risk for ALI and limb events and hospitalization is so high that, of course, this cost-effectiveness analysis is important, and I expect it to be positive for this treatment. There's another question coming in, Hendrik. And it's again about the use of clopidogrel and aspirin and rivaroxaban. It's important for the understanding, because it's asking whether it was started with aspirin and clopidogrel and then switched over to clopidogrel. No. The design was that within 10 days, rivaroxaban was started on top of aspirin. And if the treating physician thought it was necessary to use clopidogrel, then the patient received rivaroxaban, aspirin, and clopidogrel. And as was pointed out, unfortunately, we do not have any data to support the use of clopidogrel. The CASPER trial was negative, that was vascular surgery, and the CAMPA trial, looking at clopidogrel plus aspirin versus aspirin alone, failed because it did not enroll sufficient patients? So this question is still unanswered.
Okay, I think we should proceed. We're exactly on time, which is very nice. And we just heard the clopidogrel data, which mainly are relevant for the endo procedures. And I know Mark has an endo case now.
Yes, thank you. So this is a similar case, 61-year-old male, type 2 diabetes, obesity, hypertension, dyslipidemia, is on metformin, glipizide, is on a beta blocker, is on a low-dose statin, and is also on aspirin. And so presents with a left limb medial ulcer. For the patient says 3 weeks, but we know that's probably not accurate. No palpable pulses, an ankle pressure of 85, and reduced PVRs in the affected extremity. So this patient meets the definition for CLTI, having a wound present in a neuropathic condition for more than 2 weeks and some level of PAD with the ankle pressure that's probably falsely elevated anyway. So as is typical with these patients on an arteriogram, the patient has a single tibial runoff here in the posterior tibial, and there are a number of different areas of stenoses, and that's providing circulation to the foot. So the patient undergoes multiple balloon angioplasty of these various stenoses to improve the inline flow. You see a modest increase in the ankle pressure from 85 to 100 and improvement in the PVRs. So now you're at this situation where you've got a tibial endovascular revascularization, and you want to at least keep it open long enough to heal this wound. And obviously the wound's multifactorial, but circulation's a component. So, prior to Voyager and Compass, maybe the question is which of these therapies? And we would make the argument that the dual pathway therapy would be with or without a brief stint of dual antiplatelet at the same time, as Sebastian has nicely outlined in his talk previously, would be the treatment of choice now for this patient, and would replace just standard dual antiplatelet therapy. And so going back to the Voyager trial, you can see that for the predominantly limb events, as we'll see in a minute, but the overall results, you see a separation almost immediately. You see an absolute risk reduction of 1.5% at 6 months, 2% at 12 months, and almost 2.6% essentially at 38 months. And as you saw with Sebastian's slides, there was a slightly greater effect on the patients who weren't getting DAPT, but there was also an increased bleeding risk. And so the predominant component, of course, is the limb events, which is what you're trying to prevent as the vascular interventionalist for these patients. And so I think for the endo case, there's excellent data and great argument to make for the dual inhibition pathway being the treatment of choice now. And if you're going to use DAPT, you would use it as Sebastian recommended for a short course only, because you don't get a great improvement in efficacy, but you do increase bleeding risk some. So I'll turn it back to Sebastian. And he's going to talk some about chronic limb-threatening ischemia and surgical bypass.
Maybe some questions. This is question to you, Mark. We are very liberal. If we have a patient like that receiving for 4 weeks aspirin, clopidogrel, and rivaroxaban, we are very liberal with PPIs. Would you use a PPI in a patient like that, or what is your management there?
Yeah, we have not gone to prophylactic PPIs with our patient, although I think it's a great idea. You know, GI bleeding is the #1 thing that was a bleeding risk in both the trials. And so it makes sense. And there was an extra arm in COMPASS, which I'm not sure if that particular study is.
In COMPASS, it was actually a factorial design, and it did not provide any benefit. So right. From COMPASS, we do not have to do this PPI. That's why I'm asking you. There's no evidence to support that. We're very liberal on that.
Well, I think, you know, part of the problem you run into is that the bleeding events that affect the vascular interventionalists are related to the intervention. So if the patient comes in with a GI bleed, that's not usually being admitted back to your service. So you may or may not even hear about it until the patient comes back to clinic.
Yeah.
And so, you know, it sort of makes politics, you know, all politics are local. It's not something per se. And there's, as you mentioned, not really data to back up that strategy either. So it's not part of our practice.
So we actually also have a question for a cardiologist, Rupert. Mm-hmm. And for a patient with a heart rhythm disorder and after revascularization, what drugs and in what dosage would you prescribe?
Yeah, that's a difficult one. So that's a patient with atrial fibrillation. That patient requires full anticoagulation, but now he's undergoing this procedure, distal procedure. And fortunately, we have some data on these patients from the PIONEER study. In the PIONEER study, patients with coronary intervention and atrial fibrillation received 15 milligram of rivaroxaban and in addition clopidogrel without aspirin. So that is a treatment that was far safer than triple treatment with VKA, aspirin, and clopidogrel. So that's the PIONEER regimen. I think that's also something that could be used.
Okay, well, maybe we should now turn on to surgical patients. And we have a surgical patient and also analysis of the surgical subgroup of the Voyager trial. Sebastian, please.
Can we have the next slides, please? So I would, these again are my disclosures. Again, go back to the retired carpenter, same case, but with a different solution. You already know his prior history. He has a severe claudication, increasing by time, has his cardiac comorbidity, 10 years diabetes, and ex-smoker. Next slide, please. Can we have the next slide, please? Here again, we see the occlusion pattern, and distally, we only had the peroneal artery and the posterior tibial artery as a patent vessel, with the posterior tibial artery as the leading vessel. So we decided here now to go ahead and perform a reverse vein bypass here on the posterior tibial artery. You see the distal end to side anastomosis widely patent with a good runoff distally. And we see again his blood pressure levels showing that there is a pressure of 168 in the posterior tibial artery, which almost reaches normal levels now. Next slide, please. So nice procedure, nice surgery, was successful. The patient is happy, can walk again. How do we treat him in terms of antithrombotics and anticoagulations? You already have seen this slide, which shows one of the most important randomized clinical trials trying to give an answer on this question. The CASPAR trial failed to show that aspirin and clopidogrel was superior to aspirin alone. In opposite to this, there were more severe bleedings in the treatment group. And also the Dutch BOA trial was not able to show overall that oral anticoagulation is better than aspirin alone. Next slide, please. The problem always is acute limb ischemia following surgery or also endo treatment. And this is a very interesting slide which gives us a hint to the risk of ALI patients in comparison to patients with acute myocardial infarctions. And we see in the red lined results that mortality rates of the cardiac myocardial infarction patients is at 1 year 8.1%, recurrent MACE rates at 1 year 3.4%, and heart failure following STEMIs after 1 year is 7.4%. This is a limited risk compared to the ALI group, which has a much higher mortality after a year, leading to 12%, MACE rates of 11%, plus recurrent ALI levels of 24%, and amputation at 1 year, which counts to 27%. So these patients are at severe high risk. Let's come back to the trial design of the Voyager trial, and we see that we included surgical patients as well as endovascular patients. Both were randomized into rivaroxaban plus aspirin to aspirin alone. Next slide, please. These are the overall endpoints. Rupert Barzak's already showed them in his first initial presentation, so I can go over this. Here we see that even 35% of all included patients received surgical reconstruction. And this meant that 52% out of those 35%, so 1,106 patients received bypass surgery, 707 patients femoral endarterectomy, and 316 patients endarterectomy plus a bypass procedure. Let's have a look at the characteristics of those patients and have a look at the primary composite endpoint in this surgical group. And you may recall that the overall results showed a primary composite endpoint with a number needed to treat of 39 patients. Here in this surgical subgroup, we even see that this treatment obviously is even more efficient, with a number needed to treat of 24 only. Despite of this, the curves are accruing very similar, so the effect of this treatment seems to increase over time. Next slide, please. Also, in terms of the different endpoint components, rivaroxaban showed benefits in comparison to aspirin alone. Next slide, please. If we look at the event-free survival in surgical patients treated with rivaroxaban, we again realize a benefit for the rivaroxaban group, reaching a number needed to treat following 3 years of randomization of 26 patients, which shows that this treatment is highly effective. Again, next slide, please. Again, the crucial topic is safety in surgical patients in terms of bleeding. And this actually was our all fear, that surgical patients would probably intend to bleed more than endo patients. But this obviously is not the case. There are no statistically significant increases for bleeding in the surgical subgroup compared to the general the surgically treated patients receiving only aspirin. So there is just a slight numerical increase here, but without reaching significance level. Next slide, please. Also, peri-procedural bleedings, as you can see here very nicely, did not exceed in the rivaroxaban group. Next slide. So I would like to conclude that symptomatic patients undergoing surgical revascularization are at very high risk of irreversible harm events of the limb, heart, and brain, in spite of available medical therapies. However, a strategy of rivaroxaban 2.5 milligrams twice daily added to aspirin should be considered in patients who are not at high risk of bleeding, initiated after hemostasis is achieved, to be continued long-term with benefit demonstrated from Voyager PAD to Compass. Thank you very much. So our conclusion coming back to this patient would be to give this patient long-term rivaroxaban 2.5 milligrams twice daily plus aspirin for a lifelong period, and start this after bleeding has achieved, and this would be the day when we put off the drain.
Thank you very much, Sebastian. And I think this was very clear, and I would like to make a comment on this thing with the numbers needed to treat. The overall data showed that the numbers needed to treat after 3 years was 39. And in the surgical subgroup, it was 26 also after 3 years. And of course, you showed that the event rate was higher, which of course explains part of the story. Now, I'd like to just for those who are not used to speaking in these terms to compare. Surgeons think that, oh, you need to treat so many patients just to, prevent one event. But if you look at antihypertensive treatment, and if you look at the treatment of moderate hypertension, which a lot of people have, you need to treat 100 patients for 5 years to prevent one major event. So really, this treatment is actually quite effective compared to other preventive regimens. But Sebastian, getting back to this lower number needed to treat here, why was the event rate higher, do you think, in the surgical subgroup?
Well, the surgical subgroup represented different characteristics to the endo subgroup. So the comorbidities were different. The lesion lengths treated were longer, and the severity of PAD was higher. So we had more Fontaine stage 3 and 4 patients than in the endo group. And I think this all counts to this risk.
We have a question, and maybe this is for Rupert. For younger and more fit patients, would you still go for aspirin and rivaroxaban?
Yeah, that's a good question. Yes, absolutely. These patients have, the young ones have a longer lifetime benefit. And also, as we know, if a patient in young age presents with PAD, there's a high risk profile. So this patient has a double benefit from that treatment. Also, the young patients, of course, have a lower bleeding risk. So clearly, yes, young and fit patients have the biggest benefit.
We also have a question, this is actually for you, Sebastian. It comes back to the clopidogrel subgroup, and it is being asked, how many % of patients were on clopidogrel in each arm of the trial?
That is a good question. Almost 90% of all endo-treated patients receive clopidogrel, whereas around 10% of the surgical subgroup receive clopidogrel. So there is, of course, a big difference between those two groups.
So we have a question from Bulgaria. It says, I'm a vascular surgery trainee in Bulgaria, but unfortunately we do not have rivaroxaban 2.5 milligram available. Might that change in the near future, in your opinion? Well, I guess this is difficult. Who can answer that?
I don't know. Well, it's labeled. It's a European label. It's an American label, so it would be from a label point, it would be available, but it may take some time. I can't say any clear answer to that. Good, Henrik. We talked about those patients that require a redo operation or intervention. And we're now looking forward to that sub-analysis on those really difficult patients who require a redo vascularization.
Thank you very much. And I'm pleased to present these data on behalf of the Voyager study group. As you can see, they were presented at the CIRSE for the first time just a few weeks ago. And the hypothesis is that symptomatic PAD patients undergoing lower extremity revasc having prior lower extremity revasc versus those undergoing the first revascularization will have a higher rate of acute limb ischemia and will derive even greater benefits with rivaroxaban plus aspirin strategy versus aspirin alone, particularly for acute limb ischemia. The presence of known lower limb revascularization was reported by the investigators at baseline and was defined as any history of vascular, endovascular, hybrid, or open surgical revascularization. The primary outcome was, as in the Voyager trial, composite of acute limb ischemia, major amputation of vascular etiology, MI, ischemic stroke, and cardiovascular death, using Koch's regression model with interaction terms to assess for heterogeneity of efficacy and safety of rivaroxaban by prior lower extremity revasc status. So as you see here, there were approximately 1/3, the blue column, that had previously undergone lower limb revascularization, and 2/3 without. And you can make a fast comparison of them and notice how that there were higher rates of hypertension, diabetes, and hyperlipidemia. So more comorbid patients had to have redo. And also notice that there was more with coronary disease, carotid disease in that redo group. More busy slide here comparing the two groups with respect to qualifying which procedure they went into the trial with. Notice that in the group without prior revasc, there was 1/3 that had surgical operation and 2/3 with endo. That was shifted more towards endo in this redo, with 3/4 having a endo redo. If we look down to the PAD characteristics in the redo, there were more cases with prior major amputation, more with prior minor or overall amputation, and a majority of patients having undergone prior endovasc compared to prior bypass. The ABI were also a little bit higher in the redo cases, and drug treatment was a little bit more intensive in the redo compared to the non-redo. So if we first look at the primary event happening in the placebo patients with no prior lower limb compared to those on aspirin only. So notice here that those that had no prior had a lower event rate overall, 17.7, and those who had prior, so redo cases, had a much higher event rate, 6% higher in absolute terms. And if we compare the benefit of the treatment, you can see that although there was a benefit in the non-operated first-time revasc group, it was much higher in those who were redo. Notice that there's an absolute risk reduction of 5.7, translating into a hazard ratio of 0.73 in those undergoing redo surgery or endovascular. If we look at the individual components, the left half of this slide is the patients with no prior revascularization, and on the right side, you see those with redo. Notice how the columns are higher to the right side because of the higher event rate, but also notice that the benefit, both in terms of acute limb ischemia, but also in terms of vascular amputations, are greater on the right side than on the left side. If we look at the safety outcome with the bleeding risk, you can see that all the risks are 2 by 2. So to the left, there's the no prior revasc, and to the right, you see the redo cases. And notice how the columns look more or less the same. And there's no difference in bleeding risk between the groups. So in summary, symptomatic patients undergoing recurrent lower extremity revasc, redo cases versus those undergoing the first revasc have higher rates of ischemic events, particularly acute limb ischemia. And despite even greater benefit of rivaroxaban plus aspirin versus aspirin alone for the composite of acute limb ischemia, major amputation of vascular etiology, myocardial infarction, ischemic stroke, or cardiovascular death with the greatest absolute benefit for acute limb ischemia. And the safety in the rivaroxaban plus aspirin versus aspirin alone is consistent regardless of prior lower limb revascularization.
Yeah, thank you very much, Henrik. Very impressive data, and it shows us that this is really a frequent problem. And it's a large benefit with the dual pathway inhibition. Are there any questions? I see one that is perhaps for Mark. If the patient has undergone revascularization and is allergic to aspirin, what would you do?
Well, I think in that situation, we might replace the aspirin with clopidogrel.
Yeah, I think that's a reasonable decision. The label really includes dual antiplatelet treatment plus rivaroxaban, and of course, clopidogrel has to be used with caution. But I think that would be a good advice here. Yeah.
We have another question here, and you might answer that, Rupert, I think, if you can. In patients with COVID-19, what do you think is the optimal antithrombotic therapy after revasc?
Yeah, difficult question, really, and that's actually not theoretical. That's what happens really now, and we know from many studies that these patients with COVID-19 have a very high thrombogenic potential. And so the advice is anyway, as long as a patient with COVID-19 has to be hospitalized, they should receive a thromboprophylaxis, high-risk prophylaxis, even a higher risk of heparin than usual. Could be an intermediate dose. It's not a full therapeutic dose, but that would be a recommendation. And that would also be a recommendation for that patient after intervention. And after discharge from the hospital, I think these patients would really benefit from the dual pathway inhibition, but this has never been studied, of course. There are interesting observations from Italy that patients who are on an oral anticoagulant, on a NOAC, for atrial fibrillation seem to have a more benign course of the disease, non-randomized, poor data, but it's interesting to note that.
I can see we have a question on the strategy on patients with renal dysfunction, but I think that actually talks into our next presentation. Yeah. By Rupert on a CKD patient and the Voyager subgroup analysis in this patient group.
Yeah, perfect. The question is just at the right moment. And you, of course, know already the retired carpenter, but he's always good for a surprise because as you now see, this patient, and we know that it's very common, has renal insufficiency. So he has a serum creatinine of 1.7, has a GFR of 47, and those patients have a high risk. And as we've discussed before, this patient undergoes angioplasty, as you can see here. So that was quite successful. But during this contrast media exposure, of course, the renal function got worse. So the GFR is 35, and you have to be aware that after surgery, after vascular surgery, after intervention, those patients really may deteriorate with their renal function. And that's important to note. And also concerning to the question from the viewer here, we have to know that rivaroxaban 2.5 milligram is in label down to a GFR of 15 ml per minute. But these patients, as we will see in a minute, have a high risk for ischemic events, for thrombotic events, but they also have an increased risk of bleeding. And only 2 days ago, that was presented by Judith Hessier at the American Society of Nephrology. And it really separates the Voyager patients into those with a GFR below 60 and above 60. And if you look at the major cardiovascular and limb events, you can see that with impaired renal function, this risk is even higher compared to those patients with a normal renal function. This, you can see again, there was a reduced risk with rivaroxaban, which was not significant because it's a smaller subgroup. But what I just said is that in those patients with impaired renal function, the bleeding risk is higher than the ones with a normal renal function, but you can see that the bleeding numbers are much lower than the thrombotic numbers. So these patients have a high thrombotic risk, so they benefit, but we need to keep close attention to the renal function, which may deteriorate if those patients have a lesion, if they have fever or have an infection and are exposed to contrast media. So the conclusion from this chronic kidney disease sub-analysis was that among patients with PAD and recent revascularization, those with a GFR below 60 have a higher risk for major adverse cardiac events and limb events. And again, rivaroxaban reduced this composite endpoint. There was no heterogeneity, meaning that it applies for those with poor renal function and for those with good renal function. And in those patients with impaired renal function, it reduced the events by 45 relative risk percent. TIMI major bleeding were infrequent, as I just pointed out, with again no heterogeneity by the EGF category. So what did we do in our patient? This patient was started on rivaroxaban 2.5 milligram BID on top of aspirin, and he received also 4 weeks course of clopidogrel. Next slide. Oops. So it really shows us that there's a continuum from the patients that were enrolled in Voyager after the acute revascularization and COMPASS that we discussed earlier. And in that slide, this is a slide from COMPASS, you can see the different risks for MACE and MALE events in COMPASS. And you can see that in those patients with a GFR below 60, the risk for suffering an event is very high in COMPASS. And these were chronic stable patients. They were not undergoing revascularization. So they have a very high risk for suffering events, and those patients have a high benefit from the dual pathway inhibition. Next slide, please. Next slide. If you look at the results in those patients with impaired renal function in the COMPASS trial, you can see that the absolute risk for MACE was very high, 8.4% if they were only receiving aspirin, and it was an absolute risk reduction of 2% with the addition of rivaroxaban, and those risks were much higher than the patients that had no impaired renal function. So impaired renal function, high thrombotic risk. Interestingly, the bleeding risk was 1% with GFR above 60, and it was increased by 1%. So the increase in bleeding was not as much as the increase in thrombotic events. Next slide, please. Okay, so that's the answer for the question about the what to do about patients with a GFR below 25. That was a viewer's question here.
So does that well, let me just be a little strict here. So do these results actually translate into those with very severe kidney disease? Because what were the inclusion criteria for kidney function?
The inclusion criteria was 15 ml per minute, so it did not go to dialysis patients below 15. So they were not included. It's a very complicated group of patients, dialysis patients, but they were not included in Voyager, so we can't say anything for those patients.
We have another question here. If these patients on aspirin and rivaroxaban are going for emergency non-vascular surgery, how quickly their effect can be reversed?
Yeah. And I think that's an important question. We had that in the protocol for the Voyager study. The anticoagulant effect of 2.5 milligram rivaroxaban vanishes rapidly. That's the reason why you have to give it twice daily. And if you want an equivalent as a vascular surgeon or an interventionalist, you would compare that to a prophylactic dose of enoxaparin, for example. So it vanishes. You would try to wait 24 hours, but if it's an emergency surgery, you can well go ahead and do the surgery and prepare that there may be some anticoagulant effect, but it really carries on only a few hours.
So, Mark, let me get back to you. We have a question here, a surgical question, actually not necessarily related to rivaroxaban, but it's very relevant. How often do you use carbon dioxide in patients with low GFR?
We use it, but sparingly. The detail's not the greatest. It's obviously, we often will use it in limited studies, unilateral, specific target interventions, things of that nature. So we're familiar with it. I would say in our practice, we do one of these maybe every 2 weeks, something like that.
Yeah, we use it for the proximal part, but if you really want to have details on the foot, you have to use a little bit of contrast media.
Right,
but if you're aware of it, and you can really save contrast media, but for the foot, you really need some contrast media. Yeah.
And I guess the point
is
I
wanted to say something about the bleeding. During the trial, I was on the the hotline to field questions that came through about bleeding events and need to potentially unblind, et cetera. And there was the thought that we were going to have a lot of those phone calls, but those were vanishingly small. We rarely had a phone call. We had a lot of phone calls during the recruitment phase of the trial, but very minimal contact about what to do about bleeding events that occurred, outside of the vascular realm.
So we have a very important question also here. Are there equivalent doses we can use for other DOACs? Would you recommend it if they don't tolerate rivaroxaban?
Yeah, good question. You have to be aware that this study was only done with rivaroxaban in that dose. And so there is no equivalence. There has been a study done with patients with acute coronary syndrome using the full dose of apixaban on top of antiplatelet treatment. And that trial was stopped because it had no benefit, but it had an increased risk of bleeding. That was the APPRAISE trial. So you're not allowed to switch from one NOAC to the other. These are specific data obtained in 3 large studies, the ATLAS study, the COMPASS study, and the Voyager study, with that dose of rivaroxaban 2.5 milligram.
And we have another one for Mark. Is there a role for this therapy, and I presume that it's dual pathway inhibition, in claudicants who don't need endo or open surgical intervention?
So that would be the COMPASS patients. Yeah. And yes, there is a role. I think in that population, you do not see the limb event activity that you saw in Voyager. But the patients who did have limb events had a significant reduction in them with therapy. I think it's easier to institute a new therapy after some sort of event, some sort of procedure. But we certainly put people on the regimen who we aren't going to do an intervention on. We will do that. So, yes.
If we get back to the guidelines that I quoted in the beginning, the patient with only PAD is maybe not the highest risk case, but if he has PAD in addition to other comorbidity, for instance, diabetes, heart failure, coronary artery disease, maybe cerebrovascular disease, but PAD combined with some other serious morbidity, that's where, at least in the practice in Northern Europe and also for reimbursement purposes, is where we find the DPI very attractive.
Yeah, it's patients with trouble in multiple arterial beds, so peripheral, coronary, cerebral vascular. If they have two, increased benefit. If they have all three, it goes up even greater.
Okay, well, maybe we should get to our last presentation in our last 10 minutes here. And Mark, I think you prepared a redo patient?
Correct, yes. So we have a redo patient, so another 67-year-old male, current smoker this time, hypertension, and a long peripheral arterial disease history with intervention. So iliac stents 8 years ago for claudication, had a stent occlusion 3 years ago, underwent an aortobifemoral bypass at that time, and has now had a right limb revision of that with an endarterectomy 2 years ago, and now presents with left leg claudication. The ABI is normal on the right and 0.75 on the left. Patient's on aspirin, high dose statin, and an ARB for hypertension. So this is the duplex on the right limb that had been revised, and it looks good. Nice velocity, not elevated, and the B-mode image and color flow looks good. But the left limb has a higher grade stenosis, 413 centimeters per second. And so here's a patient with the need for a recurrent intervention who's already had multiple. And so if we go back to the rivaroxaban study, as was mentioned by Heinrich, they had a fairly large number of patients, over a third, that had had previous peripheral revascularization. And I think, this gets to the idea of the continued benefit over time after revascularization in the Voyager patient. And if you just look at the chart that Sebastian showed, I think it's important to note that Voyager represents, because this patient would need an endarterectomy in addition to the revision of the limb, that this particular study represents the largest series of endarterectomies ever. You've got roughly 1,000 endarterectomy patients, and about 70% of those had an isolated endarterectomy, which initially wasn't even part of the protocol until we had our investigator meeting in Europe, and the European surgeons said this is going to be a big part of the trial. We need to add it, so we did. And so that's a big part of the case distribution in surgery, either with or without a bypass. And when you're doing recurrent vascular surgery, I think the number one thing you're trying to worry about in that case is recurrent events from the limb standpoint. You've already had a few because that's why you're having to re-intervene in the first place. And so if you look at, these limb events are major parts of the composite endpoint. But more importantly is that this particular chart is time to first event. But, and we haven't presented the data yet on the total events, but there was a large number of secondary events that weren't part of this time to first event. And there was a significant reduction in secondary events, particularly limb events, with therapy as well. So, that's probably why you continue to see a separation of the curve, is because unlike the Compass patients, the Voyager patients, even the ones who, are getting treatment, some of them are still having recurrent revascularization. So they're sort of resetting every time they have another intervention to the beginning stage of Voyager because now they've had a revascularization again. And we all know as vascular providers that these patients end up, a subgroup of our patients end up with multiple operations. And the patient I described, if that doesn't stop, eventually you keep reoperating on the groin, you're going to infect the groin, and then you're going to have an infection of your aortobiphum graft, and it's going to become a total disaster. So anything you can do to reduce the recurrent revascularizations is going to be helpful for the patient, up to and beyond just preventing them having to have a hospitalization and having to have a procedure with a certain risk to it. It does have a downstream effect. I always say to the residents, the patient's groin is not a clown car, and you can't just keep pulling operations out of it because eventually you're going to get a disaster and an infection, and you lose vessels as you have to reoperate, et cetera. So this particular patient is a perfect example of that. So I'm happy to answer any questions before I think we're going to go to a summary.
Well, we got one question that would be maybe relevant here. Maybe not a redo case, but still interesting. How is the strategy with drug-eluting stents or stent grafts like the Viaban? Would that change anything? Did we study that?
So they're a subgroup of the endovascular cases, but it's not clear to me. I'm not 100% clear what the sheer volume of it is. I don't think they represent a huge volume of the endovascular interventions. So it's probably not something we have the end to really make a lot of statements about.
Yeah, it's interesting that to see that the use of clopidogrel was not very much longer in those patients with drug-coated devices. That was a bit of a surprise to me. The median duration was 30 days and it was 29 for those without drug-coated products. So that was a bit of a surprise here. But of course, according to the SMPC and the instructions for use, some of those devices require 1 or 2 months or even longer of clopidogrel.
I think we covered most of our questions. We've got just a few minutes left. Does anybody of you want to make any comments before I try to wrap up the meeting? Okay, well, I think I would like to thank the panelists and everybody who participated and provided us with very inspiring questions. Thank you for participating. I think that we are learning more and more about how we can improve vascular treatment, vascular surgery, or endovascular treatment with the use of antithrombotic therapy. And this is key to benefit of our patients. And we've seen this illustrated by the overall results of the Voyager trial, but especially also how the different subgroups with different comorbidity also seem to affect outcomes. And I think that the overarching sentence that I take away from both the Compass and the Voyager is the more sick you are, the more benefit you actually gain from the dual pathway inhibition. Thank you very much for staying on with us tonight, and maybe it's dinner time for most of us.
Save the date, Henrik. There will be another webinar, ESVS Webinar, on the 23rd of November. Save the time. It will be at 6 o'clock in the afternoon on the 23rd of November. Thanks for everybody.
Thank you.
Okay.